Our today's topic is all about epidemiology. Do you ever heard this word? No? Yes, I am going to tell you about the word epidemiology. This word is derived from epidemic, which translated from the Greek means upon the people. The study of epidemics, the basic sciences of public health, and the study of the distribution and determinants of health related states in specified populations, and the application of this study to the control health problems. These derivations indicates the epidemiological methods was initially used to investigate, control, and prevent the epidemics of infectious diseases such as cholera, typhoid, tuberculosis, and smallpox. Investigating the infectious diseases outbreak is still part of the epidemiology. Today, it is also applied to the study of injuries, especially those occurring in the home and at work. Chronic diseases such as cancer, coronary heart diseases, and arthritis, and social problems such as teenage pregnancies, homicides, alcoholism, and cocaine abuse. The primary reason for investigating and analyzing these health problems is to work toward controlling and preventing them, typically through the formulation of specific health policies. The epidemiological discipline has expanded from its origin as the study of epidemics to include the control and prevention of all types of health problems. It is similar to the clinical medicines and laboratory sciences, but it differs from disciplines in its focus on the health problems of population rather than of individual patients. Epidemiology is the study of distribution, and distribution is the relationship between the health problems and disease and the population in which it exists. The distribution includes the person affected and the place and time of the occurrence. It also encompasses such population parameters such as age, race, gender, occupation, income, education level, exposure to the certain agents, and other social and economic and environmental features. Distribution is concerned with population trends and patterns of diseases and exposure to a specific agent among the groups of people. Determinants epidemiology is the study of determinants of health related states and events. The determinants are the causes and factors that affect the risk of disease. Infectious diseases have a single cause. Infection of the bowel caused by the organism called the Shigella and rubella or measles is a highly contagious disease caused by a virus spread by airborne droplets or any close contact. Many conditions have the multiple determinants. in the contribution of gender, race, dietary intake, and hormonal status to the osteoporosis. Determinants of diseases are divided into the two groups. First one is the host factors and second one is the environmental factors. Host factors such as age, gender, race, genetic makeup, nutrition status, and physiological state, which determine an individual susceptibility to the disease. And other factor is the environmental factor, such as living conditions, occupations, geographical conditions, and lifestyle, which determines the host's exposure to a specific agents. Epidemiologist is concerned with groups of individuals or populations. The epidemiologist measures or count those elements that are common to individuals so that the magnitude and effects of individual variation within a population can be accounted for in studying a disease process. Difference in the rates of disease in the populations are used to formulate the hypothesis about the cause of the health problem or assess the exposure to a specific agent. For example, I am giving you an example. In the 1990s, epidemiological studies established that women could reduce their risk of bearing a child with a neural tube birth defect, such as spina bifida, by increasing their intake of folic acid. The result is that the Food and Drug Administration now mandates that grain products be fortified with folic acid to improve the intakes. Epidemiological studies have also associated low intakes of fruits and vegetables with increased risk of some types of cancers. The mechanism by which these foods may protect against the cancers are well known. The epidemiological evidence provides a reasonable basis for the action. Understand this example uh, in which I want to describe something to you that to reduce the neural tube defect births, epidemiological studies provide the basis for the folic acid intake. The neural tube defects birth defects decreasing the rate by increasing the amount of folic acid increase. The epidemiological evidence provides a reasonable basis for any type of action. In addition to enhancing our understanding of health and disease and searching for the causes of disease, epidemiology has several other uses. Epidemiological method can be used to describe a community's particular health problems and to determine whether a community's overall health is improving or getting worse. Diagnosing a community's health problem is very important. The public health department may need to know whether the number of low birth weight infants born within the community decreased or increased or remained the same compared with the previous year, and may also want to compare the community's current rate of births of underweight infants with the rate from the previous decade or with the state or national average. This information can be used to evaluate the current programs and services and determine whether they are meeting the health needs of pregnant women in the community or not. Potential health problems may also be spotted through this ongoing examination of the community's health status. For example, in the early 90s, unusual illness was observed, mostly among men living in the New York. The findings of an unusual high number of the cases are the Kaposi sarcoma, a rare cancer affecting the middle-aged man. Discovery of the acquired immunodeficiency syndrome. This finding led to the discovery of the AIDS.
Epidemiological surveillance is the ongoing, systematic collection, analysis, and interpretation and dissemination of health data to help guide the public health decision making and their actions. Surveillance is equivalent to monitoring the pulse of the community. The purpose of public health surveillance, which is sometimes called information for action, is to portray the ongoing patterns of disease occurrence and disease potential. So, investigation, control, and prevention measures can be applied efficiently and effectively. This is completed through the systematic collection and evaluation of morbidity and mortality reports and other relevant health information, and the dissemination of these data and their interpretation to those involved in disease and public health decision making. Morbidity and mortality reports are common sources of surveillance data for local and state health departments. These reports generally are submitted by healthcare providers, infection control practitioners, or laboratories that are required to notify the health department of any patient with a reportable disease such as AIDS. Other sources of health related data that are used for surveillance includes reports from investigations of individual cases and disease clusters, public health programs, data such as immunization coverage in a community, disease registries, and health surveys. Surveillance relies on a simple system to collect a limited amount of information about each case. Not every case of disease is reported. Yes, it is true. Not every case of disease is reported. Health officials regularly review the case reports they do receive and look for the patterns among them. These practices have proven invaluable in detecting the problems, evaluating the programs, and guiding the public health actions. Public health surveillance has focused on communicable disease. Surveillance systems exist that target injuries, chronic diseases, and birth defects, occupational and environmental related diseases, and health behaviors. Because epidemiologists are likely to be called upon to design and use these and other new surveillance systems. An epidemiologist's core competencies must include design of data collection, instrument, data management, descriptive methods and graphic, interpretation of data and scientific writing and presentations. Surveillance provides information for action. One of the first actions that results from a surveillance case report or report of a cluster is investigation held by the public health department. The investigation may be as limited as a phone call to the healthcare provider to confirm or clarify the circumstances of the reported case. It may involve a field investigation requiring the coordination efforts of dozens of the people to characterize the extent of an epidemic and to identify its causes. The objectives of such type of investigations also vary. Investigations often lead to the identification of additional unreported or unrecognized in persons who might otherwise continue to spread the infections to others. For example, one of the hallmarks of investigations of persons, the disease is the identification of the contacts of the patients. When interviewed, many of these contacts are found to be infected without knowing it and are given treatment they did not realize they needed. Identification and treatment of these contacts prevents the further spreads. For other some diseases, investigations may identify a source or a vehicle of that infection that can be controlled or eliminated. For example, I will give you another example. The investigation of a case of E. coli infection, which usually focus on trying to identify the vehicle, often ground beef, but sometimes something more unusual such as fruit juices. By identifying the vehicle, investigators may be able to determine how many other persons might have already been exposed and how many continue to be at risk. When a commercial product turns out to be the culprit, public announcements and recalling the product may prevent many additional cases. The objective of an investigation may simply to be learn more about the natural history, clinical spectrum, and descriptive epidemiology and risk factors of the diseases before determining what disease intervention methods might be appropriate. Field investigation of the type, such type of these investigations are sometimes called as a shoe leather epidemiology, conjuring up images of dedicated epidemiologists beating the pavement in search of additional cases and clues regarding the sources and the mode of transmission. epidemiologists who are accustomed to using systematic and quantitative approaches have come to play an important role in the evaluation of public health services and all other activities. Evaluation is the process of determining as systematically and objectively as possible the relevance, effectiveness, efficiency, and the impact of activities with respect to the established goal. Effectiveness is the ability of a program to produce the intended or expected results in the field. Effectiveness differs from the efficacy, and efficacy is the ability to produce the results under the ideal condition. Evaluation may focus on plans, operations, impacts, and outcomes, or any combinations of these. Evaluation of an immunization program, for example, assess the efficiency of the operations, proportion of the target population immunized, and the apparent impact of the program on the incidence of vaccine preventable disease. Evaluation of the surveillance system might address operations and attributes of the system, its ability to detect cases or outbreaks, and its usefulness. Basic operations of epidemiologist is to count the cases. What is the cases? Cases is a particular instance of a disease or outcome of interest and measure the population in which they arise. Calculate the rates of the occurrence of the health problems and compare the rates in different groups of people. Women is admitted to the emergency room, complaining with the chest pain, nausea, and dizziness. The physician who attending that woman orders a diagnostic workup, which confirms that woman has had a heart attack. For the emergency room physician, this woman is a patient requiring the immediate critical care. For the epidemiologist study the factors that contribute to the coronary heart disease. This woman is a case, a single individual with a confirmed diagnosis of myocardial infarction. Understand? A case is an instance of a disease or outcome of the interest. In this example, this woman is a case, a single individual. The physician and the epidemiologist share a common concerns about this woman, her risk status. Does she possesses certain characteristics that placed her at high risk for heart attacks? Can these characteristics be modified to reduce her chances of having another? If the woman does not appear to belong in a high risk group, why did she have a heart attack at this particular time? Risk is the probability or likelihood of an event occurring. In this case, the probability the people will acquire a disease but are exposed to the certain risk factors. Risk factors are clinically important signs associated with an increased likelihood of acquiring a disease. These risk factors may be inherited, others are found in the physical environment in the form of infectious agents, toxins, or any type of drug. Some risk factors are derived from the social environment, that is, your family, your community, and your culture. Others are behavioral, such as not wearing seatbelts or gaining the excess weight. Relative risk factor is a comparison of the risk of some health-related events, such as disease or death, in two groups. The two groups might be differentiated by gender, age, or exposure to the suspected risk factor. These suspected risk factors include tobacco or high dietary intake of saturated fats. Risk for the diseases or the death will be greater in the exposed group. If an exposed is harmful, for example, in the case of the diet that is high in the saturated fats, or will be smaller if an exposure is protected in the case of the diet that is high in the soluble fibers. Alright, if the relative risk is greater than 1, people exposed to the factor have an increased risk of the outcome under the investigation. If the relative risk factor is less than 1, people exposed to the factor have a disease risk of the outcome. I will tell you another example. For example, in a study of bladder cancer, subjects with high intake of saturated fats had a relative risk of 2.25, meaning they had more than double the risk of developing bladder cancer than those with low intake of saturated fat. In another study, colorectal cancer, subjects with the high intake of beta carotene had a relative risk of 0.38, which means that they had about one third the risk of developing colorectal cancer compared to those with low beta carotene intake. Relative risk can be used to compare the strengths of different associations. The relative risk of lung cancer in the individual with low fruit and vegetable intake compared to those with high intake is about 2.0. The relative risk of lung cancer in smokers compared to the non-smoker is at least 10. The association of the cancer with the smoking is stronger than its association with the low intake of the fruits and vegetables. Some of us are exposed to the certain risk factors more than other individuals. For example, workers in photographic laboratories, dry cleaning, and some industrial processing plants are exposed daily to the chloroform, highly volatile liquid. Chloroform is a highly volatile liquid that has been shown to cause the tumors in the mice and rat studies. Workers in the office buildings, and schools are typically not exposed to the chloroforms. These different rates of exposure to a risk factor allow the basic comparisons of disease rates among the individuals. Incidence is the number of new cases of a disease during a specific time period in an defined population. How frequently a disease occurs in a population? How frequently a disease occurs in a population, that expression is known as incidence. The fraction of proportions of a group free of a disease or condition that develop the disease or condition over a time period. Incidence is measured by two different steps. First one is the identification of the group of susceptible people who are initially free of the disease or condition. And the second is the examination of them periodically over a specific period of time to discover and count the new cases of the diseases that develop during that interval. Prevalence is the number of existing cases of diseases. It is the measure of frequency of occurrence of an event. Point prevalence is the amount of a particular disease present in the population at a particular point in time, usually the time a survey was done. Period prevalence is the amount of the particular disease in a population over a period of time. The prevalence rate is the proportion of persons in a population who have a particular disease or attributes at a particular point in time. The fraction or the proportion of a group possessing a disease at a specific time. The prevalence rate is measured by a single examination or survey of a group. This table summarizes the characteristics of prevalence and incidence. Prevalence and incident rates describe the frequency with which particular events occur. By calculating and comparing the rates, epidemiologists can determine the strength of the association between the risk factors and health problems. Epidemiology uses a variety of tools: clinical, microbiological, pathological, demographic, sociological, and statistical. None of these is exclusive to the epidemiology, but the manner in which they are used defines the epidemiologic methods. Following are some examples uses the investigations of the diet hypothesis to illustrate the rigorous and scientific approach of the epidemiologist. First one is observing. Many years of investigation had shown that atherosclerosis could be induced in the laboratory animals. particularly in the rabbits and monkeys, by feeding them a diet rich in the fats and cholesterol. Atherosclerosis is the deposition of the cholesterol fragments in your arteries. Physicians working in Africa, America also observed that coronary heart disease was fairly rare in the human population, whose diet tended to be high in vegetables and grains. This was the observation of the physicians. Second example is the counting the cases or the events. Vital statistics obtained from the World Health Organization show the marked differences in the deaths from the coronary heart disease among the different countries. For example, Finland having one of the highest ratio of CHD, and Greece, Japan, and Pakistan among the lowest CHD death rates. The habitual diet of the individual in these countries differed as well. Diets vary from their traditions, country to country, and regions to regions, and diet plays very important role in the prevention and the cure of the diseases. Third is the relating cases or efforts to the population at the risk. Public health officials became increasingly concerned about the number of the deaths attributable to the coronary heart disease, which was the leading cause of the death in the world population. Identifying the risk factors for coronary heart disease became a public health priority, making comparisons. One of the first large population studies to examine the relationship between blood cholesterol level and risk of coronary heart disease was the seven countries study. This project was undertaken in the late 1950s to examine the effects of difference in culture, their diets, their lifestyles, and general health habits on risk factors such as serum cholesterol level, morbidity, and mortality from the coronary heart diseases. 60 population groups involving about the 11,000 men aged 40 to 59 years was studied in the seven countries that had reliable census data and well-organized medical system. That countries was Greece, Netherlands, Italy, Yugoslavia, Japan, and US and Finland. The cohort of the adult man was followed for 10 years. Cohort is a well-defined group of people who are studied over a period of time to determine their incidence of disease, injury, or death. One of the main study findings was that the population risk of coronary heart disease deaths after adjusting for the age in a stepwise manner with increasing total blood cholesterol level. An analysis of dietary intake of study population showed that serum cholesterol level increased progressively as the level of the saturated fats increased in the diets. Finland was the highest reported intake of saturated fats, had the highest mean population serum cholesterol level. Finland, yes. The correlation coefficient is a number between -1 to +1 that is used to quantify the strength of an association between two variables: dietary saturated fats and serum cholesterol level. One variable is dietary saturated fat and another variable is serum cholesterol level. And correlation shows the association between dietary saturated fats and serum cholesterol level. The stronger the relationship of the two variables, the closer is to 1. The weaker the relationship, the closer is to 0. And the value, which is 0.8, means that although dietary saturated fat intake is strongly correlated with the serum cholesterol level, relationship between the two variables is not always perfect because of the measurement errors. Sometimes two different variables shows the positive relationship between each other. In calculating the dietary intake of saturated fats or determining the serum cholesterol level or other factors such as genetic determinants. Other is the developing the hypothesis. The results of animal studies and the large-scale population studies such as 7-country studies was used to formulate the hypothesis. What is the hypothesis? The hypothesis for that study was a diet high in saturated fat increases the blood cholesterol level and contributes to the development of the coronary heart diseases. And other one is testing the hypothesis. Many studies was undertaken to test this hypothesis. In one migration study, groups of Japanese living in Japan was compared with the group of Japanese who were originally from the same regions in Japan but im- immigrated to the California and any other part of the world. The study design used to standardize the protocols for measuring blood cholesterol and number of existing and new cases of coronary heart diseases. It showed that the intake of saturated fats as a percentage of total calories in the three population varied widely, with the Japanese living in Japan having a saturated fat intake of 7% of total calories, and Japanese living in California and other part of the world having an intake of 23 to 26%. Japanese living in the Japan had the lowest blood cholesterol level as compared to the California. Japanese living in the California had the highest blood cholesterol level. These differences in the cholesterol level paralleled the rates of the coronary heart diseases, which suggesting that changes in their diets after the migration were partially responsible for the differences in the blood cholesterol level and the incidence of coronary heart diseases. Drawing scientific inferences, results of these studies and other large-scale population studies provided the convincing evidence that rates of coronary heart disease differ among the populations, and these differences are due to the environmental factor, that is diet. The data have not been entirely consistent. The famous study held by the Ireland Boston brothers provided only weak support for the diet hard hypothesis. This study did not find the significant differences in the coronary heart diseases mortality between the Irish people who were born and remained in the Ireland and those who born in the Ireland had lived in the Boston for at least 10 years. It did underscore the increased risk of death from the CHD among study subjects consuming a diet high in saturated fat. It found that consumption of a high fiber, vegetable rich diet decreased the risk of coronary heart disease death. It is unrealistic to expect total agreement among the results of epidemiologic or clinical studies. Many genetic and environmental, social and experimental factors affects a study's outcome. Many studies conducted over the last 5 decades have strengthened the evidence for the link among diet, blood, cholesterol, and coronary heart disease. Conducting the experimental studies. Studies with rabbits and non-human primates showed that these species are susceptible to the diet-induced hypercholesterolemia. The blood cholesterol levels of some laboratory animals were affected by the types of fatty acids in the diet. In primates, blood cholesterol levels rose when a diet rich in cholesterol and saturated fatty acids was consumed. A diet rich in polyunsaturated fatty acids lowered them. Animal studies provided the support for a role of saturated fats and cholesterol in intervention and evaluation. One of the most ambitious interventions modify the coronary heart disease risk factors was the multiple risk factor intervention trial, that is MRFIT, commonly called Mr. Fit. This 6-year clinical trial was directed toward the primary prevention of coronary heart disease among middle-aged men determined to be at risk for coronary heart disease because they had hypertension and high blood cholesterol or smoked cigarettes. 12,866 eligible men were randomly assigned to special intervention groups or usual care groups. Men in the special intervention group received extensive nutrition counseling to help them make dietary changes to reduce their saturated fats and cholesterol intake. Participants in the special intervention group who smoked received the counseling to help them stop smoking. The mean reduction in the blood cholesterol in the intervention group was less than the predicted response. MRFIT showed that serum cholesterol reductions and dietary changes could be sustained over a period of several years. Mounting experimental and epidemiological evidence supporting the diet-heart hypothesis led to the formulation of dietary advice designed to reduce the coronary heart disease risk in the general population. Here is the table describing the known risk factors for coronary heart diseases and strategies for reducing the coronary heart diseases risk. These were followed by the report of the National Cholesterol Education Program on the detection, evaluation, and treatment of the high blood cholesterol in adults. The science supporting the diet heart link was eventually incorporated into the dietary guidelines, which advised the public to consume fewer calories from saturated fatty acid and to keep trans fatty acid consumption as low as possible by limiting the foods that contain synthetic sources of trans fats such as partially hydrogenated oil. Unsaturated fats have the certain degree of points of unsaturated. That point degree of unsaturation are hydrogenated by the process of hydrogenation in which hydrogen atoms are added in the unsaturated fats at the point of unsaturation. Means of reducing the risk of chronic diseases and improving the health. Here you can see the risk factor, which is high low density lipoproteins cholesterol, and you can see here also the diet used to minimize the risk, which include the vegetable, fruits, whole grains, poultry, fishes, legumes, and limit the sweets and sweetened beverages, red meats, and avoid the trans fats. And another risk factor is low high density lipoproteins cholesterol, in which you can avoid the trans fats, lose the fat where necessary, and maintain a physical active lifestyle. And another risk factor is high blood pressure, cigarette smoking, diabetes, physical inactivity, obesity, all are the risk factors. And you can see here the diet used to minimize these risk factors. Another risk factors you include stress, physical inactivity, and obesity. And here are some diet to minimize the risk factors. There are some risk factors you can't be able to change, such as your age, your gender, and your genetics. Increasing pressure to eliminate the use of artificial trans fat. Food and Drug Administration took the first step towards banning the use of trans fats in food. The FDA published a ruling in the Federal Register stating partially hydrogenated oils, which are the primary dietary source of industry-produced trans fatty acids, are not generally recognized as safe for any use in food based on current scientific evidence, establishing the health risk associated with the consumption of trans fats and partially hydrogenated oils that are the food additives. When the FDA finalizes these rules, food manufacturers will no longer be permitted to use the partially hydrogenated oils in food products without prior FDA approval.